What are the current recommendations of HIV treatment? So HIV infection is deleterious starting in the very first days following infection. And as there is no current strategy for HIV cure, HIV has to be controlled for a lifelong art. So 3 drugs combination is still recommended for all patients starting treatment. However, recent guidelines provide some recommendations for simplification in virologically suppressed patients. We know from the 90s that with SAT immunotherapy, after a virological decrease, there was a rebound in the virological in the viral load after several weeks, with the selection of mutations in the RT. And this was due mainly to a lack of potency with AZT in monotherapy. And then later, with NRTI dual therapy, there was a deeper virological decrease, but there was also a rebound after several weeks. And then with the triple therapy with 2 NUCs plus PIs, there was a deeper virological control with a sustained virological control. The reason was mainly due to the HIV quasi-species, and this was very well shown in this paper, showing that HIV-resistant variants can pre-exist in the quasi-species. And if you look at the probability of a virus to become resistant to a drug A, this was 10⁻⁴ to 10⁻⁵. And the probability of a virus to become resistant to a drug A plus B is very, very low, and even lower when you use triple combinations, with the probability of a virus to become resistant to A plus B plus C was nearly 0. So this is the explanation why we use triple drug combinations to treat HIV. So now, do we still need 3 antiretroviral drugs to achieve viral suppressions? We know that patients are now initiated at a much earlier stage of HIV infection, with a shift in higher CD4 cell count and a lower viral load. And there is a need for evaluation of lighter antiretroviral regimens, such as dual or single therapies, with potential benefits on reduced toxicity, better tolerability, less resistance, class pairing, and sometimes lower costs. So rather than triple therapy for all, the new dogma should become art and lifelong viral suppression for all. So what are the ideal candidates for such lighter therapies? They should have a high antiviral potency, a high robustness in terms of genetic barrier to resistance, and also favorable pharmacokinetics properties, such as minimal inter- and intra-variability, but I won't speak a lot about that. So if we look at high antiviral potency, some studies have shown that that PIs are very potent drugs, and that they can be a very good candidate for monotherapy, because they have a multi-step inhibition mechanism of action that can explain these PIs, pharmacodynamics, and resistance. Indeed, when cells are treated by PIs, they produce immature variants in the presence of PIs, and these immature variants are incapable of efficiently completing entry, but also reverse transcription and also post-reverse transcription steps. So PIs act like multi-drugs in one, explaining their high potency and probably their high robustness in terms of genetic resistance. So this is also showed by monotherapy studies when drugs are evaluated. And for example, darunavir showed a high potency with a reduction of minus 1.8 log in monotherapy after 10 days. But also integrase inhibitors share these properties with a high viral load decrease in monotherapy after 10 days with, for example, dolutegravir minus 2.5 logs in viral load decrease. Again, in clinical trials in naive patients, if we look at the potency of integrase inhibitors versus efavirenz or boosted PIs, all integrase inhibitors showed a high level of potency with some trials showing non-inferiority or even sometimes superiority versus efavirenz or boosted PIs. For example, you have here dolutegravir that showed superiority than efavirenz, boosted atazanavir, and boosted darunavir. So now we have very good drug with high potency, and if we look at the robustness in terms of genetic barrier to resistance, we know for many years that PIs have a high genetic barrier, and you can see in all these trials, clinical trials in more than 4,000 patients, showing that in case of virological failure in triple therapy, only 2 patients develop major PI mutations in case of virological failure. Now, dolutegravir, and this has been well explained by Charles and Jonathan, dolutegravir has also a high virological robustness with a long dissociative half-life from the integrase, a high inhibitory cushion, a high virologic potency in monotherapy, and to date, in randomized clinical trials in naive or suppressed patients, there are no resistance mutations after failure in triple combinations with dolutegravir. So this is the reason why we tried monotherapy, because we have high potent drugs with high genetic barrier. So the strategy that has been the most studied in monotherapy is boosted PI. You see in this paper, this is a meta-analysis of data from more than 2,000 patients treated in monotherapy versus triple therapy. And all these trials showed that monotherapy performed quite well. There is no difference versus triple therapy, with no increase in the risk of emergence of resistance. However, even if boosted PI monotherapy is possible, there is some criteria that you have to keep in mind. Patients have to be highly adherent, with no previous CNS disorder, with an IDR CD4 above 200 per cubic millimeter, and you have to look also at some virological parameters. And some studies show that the good candidates for PI monotherapy should have at least 12 months of virologic suppression before the switch, a very low level of residual viremia, because in this study performed by Sidonie Lambert, she showed that when patients have a viral load below 1 copy per ml, there was a low risk of virological failure under boosted darunavir. And for example, in the French guidelines, it's recommended to to use boosted PI monotherapy if the level of DNA of the reservoir is below 200 copies per ml, and shouldn't use this strategy if you have a HIV DNA above 1,000 copies per million cells. And of course, no previous failure of resistance and no HPV chronic infection. So PI monotherapy is possible, but not for everyone. And Charles reminded us the results of dolutegravir monotherapy within the DOMONO trial, and this strategy performed well up to week 40 weeks, but at week 48 weeks, there was a big difference between patients who were on monotherapy versus triple therapy, and with a high rate of virological failure. And what is very important in my mind is like you have failure, but in case of failure, 3 of the 6 patients who were in failure developed resistance mutations to integrase inhibitor with, as you can see here, signature mutations to dolutegravir. So this strategy is definitely not recommended. So now for dual therapy, there are a number of studies that have evaluated the dual therapy with boosted PI plus 3TC. For example, you have the dual study that evaluated boosted darunavir plus 3TC, and this strategy was non-inferior to triple therapy at week 48, with no resistance mutations in the 2 patients who experienced virological failure. Again, in the ANRS MobiDeep trial, after viral suppression with boosted PI plus NRTI in second-line ART, a maintenance therapy with boosted PI plus 3TC was associated with a higher rate of success than PI monotherapy. And it was very interesting because most of these patients have in their history 184V mutation as first before the switch. And as you can see, the paper was published this summer in Lancet HIV, and you can see the difference between the 2 arms, between the monotherapy arm and the dual therapy. And these results remind us that in the presence of the 184V, there was a reduced replicative capacity, suggesting that the residual activity of 3TC may prevent virological relapse in combination with boosted PI in patients already suppressed. So now other dual regimen strategies have been evaluated with integrase inhibitor-based regimen, first with NRTI and then with 3TC. For integrase inhibitor plus NNRTI-based regimen, the ANRS ETRAL study evaluated a switch with raltegravir plus etravirine and showed that this strategy was effective in maintenance of viral suppression at week 48. However, we showed that 1 patient failed with resistance mutations to etravirine, and the virus become resistant to etravirine. And if you want more detail, you can see this presentation during the EACS meeting. The SWORD study evaluated the association with dolutegravir plus replivirine that was non-inferior to continued baseline ART, and only 1 patient developed virological failure with no integrase inhibitor resistance, but a selection of an NNRTI resistance mutation. And finally, the lamidol trial evaluated the switch of dolutegravir plus 3TC in maintenance, in virological suppression at week 48, and with no resistance in the 3 patients who developed a virological failure. So these results were from virological suppressed patients, switch studies, and at the EAS meeting this summer, it was presented the ACTG trial evaluating dolutegravir plus 3TC in naive patients, and this trial showed that there was 3 virological failure, and 1 patient selected 1 interferon plus 263K with dolutegravir resistance. So I would be very cautious about this strategy, and I think we will wait for the larger clinical trials result from the Gemini study. So in conclusion, in my virological point of view, triple therapy remains the gold standard in terms of resistance, because there is no resistance in case of first virological failure with boosted PI or dolutegravir. However, we have drugs with high potency and high genetic barrier to resistance, so we have to, we know that HIV treatment is currently evolving towards individualized therapy, and we have to adjust chronic therapies to each individual. And for example, in our center, now approximately 20% of patients are receiving dual therapies. So we absolutely need to have more data about these strategies. Regarding monotherapy, I think the story now is very clear, and the story is ended with dolutegravir. Monotherapy is not recommended because this strategy showed an unacceptable risk of resistance in case of virological failure. However, this strategy remained possible with boosted PI, mainly with boosted darunavir. However, we know that with this strategy there is a low-level viremia, and we have to respect some clinical and virological parameters to choose this strategy. And in my experience, this represents only 4% of patients in my clinical center. So dual therapy is going to be, I think, more and more used in virological suppressed patients. We have several options, either with boosted PI or with dolutegravir. RT inhibitors are still needed in combination, 3TC or NNRTI, and 3TC may be substituted to 2 NNRTIs, even it shouldn't work. And it's better than monotherapy. And I think we really need more resistance data in case of virological failure in routine care with dual therapy, because we need to know if there is a higher risk of resistance with this kind of strategy versus triple therapy. We have data from clinical trials, but we have not many data in clinical routine care. And for dual therapy in naive patients, I think we need to wait for results of large clinical trials of the Gemini study. And we keep in mind that if you stop 3TC, FTC, or TDF in patients, there is a risk of HBV reactivation if your patients are chronically infected. So I would like to thank all my colleagues from the Pitié-Salpétrière Hospital, and thank you for your attention.